Hey everyone, this is Brooke, and today I'm going to talk to you about a case I had in the emergency department recently where ultrasound helped me narrow down the differential diagnosis for a patient who presented to the emergency department with a headache. So, this patient, she was 22 years old, otherwise healthy, but had obesity, who presented with a chief complaint of a generalized global headache that was progressively worsening for 2 months. And she has no history of headaches at all. Also, no focal neurologic complaints. She had a little bit of nausea intermittently, but no vomiting. And I couldn't find anything else on review of systems. No fevers, neck stiffness, photophonophobia, recent travel, no red flags otherwise except for this headache. And she had actually been to her primary care doctor a couple times for this and was getting analgesia. And she also had a non-contrast head CT scan in the last week. And this is just one slice of her head CT. Not trying to trick you. It was read as negative. There was nothing remarkable on the CT scan. But she came to the emergency department that day to get a second opinion because she was just having trouble sleeping at that point. So I performed my physical exam. Vital signs were normal. Besides being obese, there was nothing else remarkable on her exam. She was completely neurologically intact. But one thing I wanted to do was make sure I did a good fundoscopic exam. And I don't know about you, but my fundoscopic exam skills are not the best in the world. And often it's really difficult and almost impossible to have the perfect environment in the ED to get a good look at the back of the eye. So, of course, I get my ultrasound out and take a look at her eyes. And here, it's a little bit more gray because I turned up the gain. Take a look at the eye, but just to kind of get a lay of the land, this is her globe here. And this is her lens. This is the optic nerve sheath. And my eye was really drawn to this area right here. If you see this little elevation in the back of the eye, that's a swelling of her optic disc. So she had papilledema, at least on the right. So I wanted to take a look on the left and confirm that it was bilateral. And same thing you can see in the back of the eye. In fact, it was a little bit more prominent on this left side. And if you look at the video side by side, you can definitely see, especially compared to the video of the normal eye in the bottom of the screen, where the optic nerve and the optic disc is very flat compared to the left and the right eye of the patient where there's definitely a prominence. So I measured it, and the right side was about 1.5 millimeters, and the left was about 2 millimeters. Definitely an obvious elevation, even if you're not measuring it. So what I did for the patient is I called up neurology. I told them what I found on my exam, discussed it with them, whether or not to do an LP in the ED or if they can see her urgently in clinic that week. So they were able to arrange a rapid neurology clinic follow-up in the next couple days. And when they saw her, they diagnosed her with idiopathic intracranial hypertension, also known as pseudotumor cerebri. She was started on acetazolamide, which tremendously helped her headaches, but she's also scheduled for an outpatient therapeutic lumbar puncture. So this is just a look at what ophthalmologists can see on their really fancy cameras and taking a picture of papilledema in the back of the eye. And here is a picture of the ultrasound I took of this patient. The question is how good is bedside ultrasonography at detecting papilledema? And papilledema is not as well studied in ultrasound as optic nerve sheath diameter. But there was a paper in 2013 from the Academic Emergency Medicine Journal, which looks at point-of-care ultrasound for optic disc swelling. It was a small study, but what they did was determine two cutoffs, one at 0.6 millimeters and 1 millimeter. And for the maximum disc height of 0.6 millimeters, this is the cutoff that they recommend to increase the sensitivity for patients in detecting papilledema. It's not as specific, but if you get up to 1 millimeter, your specificity greatly increases, and the likelihood of pathology going on is greatly increased. So some take-home points from this case: ocular ultrasound is a great option when your fundoscopic exam is difficult or nearly impossible to perform, or if you're just not good at it, like I am. And papilledema is optic disc swelling caused by increased intracranial pressure. However, it does not tell you necessarily the etiology of the papilledema. It's just a piece of evidence, just like you would use with any kind of data in the emergency department. It could be from MS, it could be from bleeding, it could be from idiopathic intracranial hypertension, as in this patient, or hypertensive emergency. So you have to think a little bit broadly. And this patient was a little bit textbook because she was otherwise a healthy, obese woman with a new onset headache for 2 months. And remember that it's not a perfect test. It's not as well studied. And the recommended cutoffs from that paper that I showed you was either 0.6 millimeters to increase your sensitivity, and anything above 1 millimeter has better specificity. Please visit our website, and if you have any questions, just shoot any of us an email. Thanks so much. Bye.